you. So I recognise a few faces and names, and sunny afternoon. So I'll give you sort of a short talk for half an hour, and then some questions and answers, and you can ask me whatever you like. You know, the floor is open to you. Many of you know where our clinic is and where we work. And about a third of our patients have HSP, roughly. It's probably increasing, actually, as time goes on, although COVID hasn't helped us because the hospital has been in slight disarray in terms of their booking and letters and everything. So apologies for that, but I'm hoping numbers will increase slowly. So you know where I work and what we do. And we're going to talk about this disorder, HSP, talk about genes, talk about the needs of patients and what we can be doing. And then we'll talk about what the future holds in terms of what we need to try and get drug companies interested in developing treatments, which is something I've been trying for a few years, but I think with further help and emphasis on this, I think we'll improve this. So here we go. So just in terms of this slide, this is to say, I mean, HSP is a group of genetic conditions. So they're genes that cause the disorder. And this is this circle on the left. And that's part of a kind of a mountain, really. And the left mountain range is the single genes, and the right is tumors and fractures and bleeds. And I think the most important thing about the patients with HSP is, even if we haven't found your gene, you're all going to have a gene causing this disorder. I mean, I've got several genes that give me no hair, that give me, I don't know, whatever features I've got, but these are all going to be genes that cause these disorders. And I think it's very important when we see you to us to not always blame HSP on different conditions, but that's going to be primarily the main problem with that big circle. And I'm just going to show you a video now, and these few slides will be talking about patients, what problems they have, then genes, but the video will help me just show you what I mean by some of the terms I'll use. And this is a video for some colleagues in Australia. I do lots of videos on our patients for teaching, but I didn't want to show any of our patients because I didn't want to embarrass anybody on the call. But this is just to show you some of the descriptions. I'll mute the volume. Here we go. So when we see patients, typically they have a long history of walking problems. And as you can see with this man here, he walks on his toes, got quite a stiff gait. His legs are quite straight. And as you watch him, and as you can see, he catches, oh dear, I don't know what happened there. He catches his feet as he walks, catches the insides of his feet. And that's what we would call a spastic gait. Stiff, catches his feet. And the same as this man, part of the same family. He's not so bad, but he's still got a stiff gait. Arm swing is good. That's just the stiffness in the legs. And then when we look at your feet, this is what's called clonus, this juddering. And that's part of the stiffness as well. And you can cause this by pushing on people's feet. Then we look at our next patient. Some of our patients also have a little bit of tremor in their hands. It's not always. It's like some patients have some slight numbness in their hands and fingers, like this young man has. So he's more tremulous. But he also walks on the insides and the tips of his feet, and he's got quite a stiff walk as well. So it's just to show you some of the terms of what I mean. And when we say spasticity, we're not being rude. It's an old-fashioned term, really. He's not bad at tandem walking. is pretty good, but many patients do have problems with tandem walking. And it's usually the stiffness, which means that you can't take a step back and steady yourself. Okay, so that was a few terms. And then just to go over, so really we know this, it's stiffness, it's balance, speech problems, bladder and back pain. And I was talking to Adam about this. You know, we say 1 in 10,000 people, so perhaps roughly 10,000 people in the UK, but we really don't know this. And we don't know the population breakdown. And I was chatting to Adam, and I managed to get a medical student who's going to look at this over the summer. So this is a girl who's at Southampton University doing medicine, and she did her MSc in our lab 2 years ago, and she's come back and she wants 3 or 4 months of academic work to then look at the prevalence of HSP. So contact all of our colleagues like Chana, like Evan, all of our friends and people that see HSP, and really survey everybody. And then not just in the UK, mainly in the UK, but also look outside and give me some idea of the numbers and of the types of HSP, because all I have at the moment is my experience, my clinical practice, which I think probably reflects the UK, but I think this is a really nice project to be done. So that's Aisha is her name, and she'll be doing that now. And as I said, roughly 2 types of HSP, I would say. There's the pure patients, and pure, I mean they have the triad of stiffness, balance, bladder problems, and back pain. Interestingly, many patients with pure HSP have incredibly strong arms and shoulders, just because they're using their arms constantly. But that's the triad of pure. And then the complex HSP, which is basically the triad plus other symptoms. So this is not only the pure symptoms, but also things like memory and thinking problems, seizures, deafness, neuropathy. Sometimes people have quite severe speech problems, quite severe slurring, and that's that's a typical feature as well. And the reason we worry about that, slurring and speech problems, I always worry about people getting chest infections from that. And these are the reasons why we like to document this, so I know what to look for. And then when we talk about inheritance and genes, and just go back, sorry about this. So we talk about genes, and there's a lot of genes. The genes is a complicated thing that most GPs won't understand. Many neurologists won't understand, just because it's not that they're not interested, but there's just too many for them to keep up. And that's probably the reason. So one gene will be in each family, but the number of genes we see probably is up to 70 or 80 now. And that's why it's difficult to keep up. And the commonest in this country is looking at, sorry, I'm just gonna, so we talked about inheritance, and I'm just going to talk about how we get to your gene. How do we find the gene? So I wanted to show you some pictures of DNA and blood, just to sort of really go from when we see you in clinic, we talk to you, we examine you, then we look at your MRI or your CT. Sometimes we do a video, do a family tree, and then we take your blood. And you'll have all had this done. And what happens to your blood, it then goes to my lab, which is next door. If you've been to the National Hospital, our lab is right next door. And that's where all the diagnostic tests are done. And they extract this DNA. And DNA is really like phlegm, like sputum. It's usually clear saliva type constituency, and we extract that. Usually it takes 2 or 3 days, And then that's stored in the lab for testing. And then when we test it, we cut it up into lots of little pieces. And then the bit in the middle really is sequencing all of the genes on a large DNA sequencer, and then aligning them all together and looking for the difference between versus people that don't have any disorders, so controls or normal individuals. Or if there's a family, we would compare you to your mum and dad or your brothers and sisters, which is really the best way of doing it if possible. So that's the process of doing it. It all starts with the blood test and the extraction of the DNA. And then when we say the commonest in the UK is dominant genes, and so spastin is the commonest dominant gene in our patients. And if I took everybody in clinic, it's probably about 45%, something like this. I did have another girl who did this as her MSc project 5 or 6 years ago, and she did sort of a database. It was kind of she did a reasonable database, not really exactly what I wanted, and you kindly funded some of that to help her get this database together. It was good, and in the end, she collected roughly about 400 patients and families, and out of that, she got about 160 spastin patients and families out of that numbers. And spastin is inherited from mum or dad to their offspring, as you can see in this little figure. The big red A gets inherited, and it's 50-50. And that's the commonest way. Many patients with spastin may not have a mum or dad who had the disorder, only because, well, if your mum or dad died early, or many older patients just don't go to the doctor. It's quite common for, I mean, I think of my parents, they hate doctors. They're not doctors themselves, and they would only go if they're, really struggling. And I think years ago, when people had to pay for doctors, not many patients actually sought medical help. So that was dominant genes. And the commonest ones, we go back, a spastin. That's 25. I put 25%. I think from Viorica's work, it's about 40% based on our numbers. But again, this is another reason why I'd quite like Aisha to really do a good job, because I'm giving you figures here from previous MSc students 7 or 8 years ago, figures in my mind and Professor Wood's mind about the frequency. So you're getting my opinion, and what you really want is the facts. That's much better. Then adlastin, REAP. These are rarer genes, adlastin and REAP, but they look like spastin, the patients, in terms of the problems they have. So they're the dominant genes. And then the recessive genes, which is genes like SPG11, SPG15. These are rarer. So we thought, interestingly enough, some of the genes are we're seeing much more frequently because of the 100,000 Genomes Project and because of the UK Biobank. So 5 years ago, I would say SPG11 is the commonest recessive, but that's not the case now. I think probably SPG7 is the commonest, paraplegin, and that's because of the sequencing that's been done. So again, that's helped us understand that a little bit more. And with recessive genes, this is where you need 2 big A's to get the disorder. So it's where you need one from mum and one from dad, but mum and dad are fine. And roughly it's 1 in 4 children would get the disorder. So that's recessive inheritance. And then we look at the genes. As I say, SPG7, paraplegin, is now the commonest. It's interesting, when we look at the UK Biobank data, there's one SPG mutation that's in around about 1 or 2% of the population. So 1 or 2% of the population are a carrier of this SPG7 mutation. And if they happen to get together with another person who's also a carrier, then you get the disorder. So I think it's commoner than we think. And I think because of UK Biobank, I think we're missing lots of patients, certainly in areas where they don't have a neurologist interested in this disorder. I mean, I know most of the guys that are interested, and there's quite a few areas of the country that are kind of missed and neglected, shall we say. And I think particularly with COVID, many of those patients wouldn't have been referred because GPs are just not seeing anybody at the moment, are they? I think very few of them. And then you've got SPG11 and SPG15, which are, I would say, more severe than SPG7, but they're still relatively prevalent in terms of patients we see. Right. Then making a diagnosis, here we go. It's really what I said before in terms of the first slide. It's getting referred, seeing us, examination, always do an MRI. So if you haven't had an MRI of your brain or your spine, you should do, because we always need to make sure that there's nothing in your brain or spine that's causing it or making the disorder worse. Because you don't want to be labeled as HSP and then have your doctor blame everything on HSP, because you're just as likely to get any other condition that anybody else will get as well. So you just have to be a little bit cautious about that. And I always make sure that happens. And I like to see the scans myself when possible. And then our clinic. So, I mean, I try and, over the years, we've tried to improve our clinic as best we can with the limitations of the hospital. So the hospital are always trying to reduce our rooms, make us have less doctors. So there's always me and Professor Wood, but they're always trying to dumb us down, shall we say, and give us less. So we're quite angry about that. Nick is particularly angry. And so we have a specialist nurse, and we have access to investigations, which is a good thing. And if you said to me, is it improving? I think the genetics is improving. I think the hospital is on a par at the moment, just because they're struggling given the recent years. But I think the telephone consultations are good for some patients, but I do think everybody really needs to be examined really every year, but if not every year, every 2 years, because otherwise you miss things, and you miss, and talking to somebody over the phone is really not as good as talking to them face to face, especially with tablets, going over what they're taking. There's been mistakes in our hospital. There's been mistakes with people telling me what tablets they're taking. It's quite hard for them over the phone as well. So I think that's the way we like to do things. And then when we think of not only the diagnosis, but managing patients, I don't know why I put tested positive for spastin here, but say if you have spastin or any of the types of SPG, at the moment we're limited with treatments that can support you. So we don't have anything that can reverse this disorder. And I'll come on to that a bit later. That's something that we really want, but we don't have. So we can support with things like physio in your legs, orthotics. We can try and get those for you. We have a very good orthotics department in London, but of course you need to come back several times to get the right orthotics, to get the right insoles for yourself. So ideally do it locally if you can to reduce trips. Drugs like baclofen, I think some people get on with that drug, or tizanidine or dantrolene. They're reasonably good drugs, but they do make some people very drowsy, and they make some people quite confused some of the time, quite clouded in terms of their thinking. So they have their limitations. And the same with the bladder problems. I often try different things. I put tetrusitol here. That's one of the tablets that tightens the bladder up. Some people use self-catheterization. But of course, not everybody can do that. Not everybody's got good hand function, and some people are a little bit squeamish about putting a catheter in themselves. And then things like sticks are important for some patients. A high stick is often quite good because it doesn't make you look disabled, although it still has function. You walk and making sure you get a seat, for example, on the tube or the bus. So I think they're important things for sticks. And then to keep an eye on your hips and knees. This is quite important when we see you in clinic, because in patients getting into their 60s and 70s, very common that you'll need a knee replacement or a hip replacement with pain, just because of the way you walk. It doesn't matter how good you are, you can't avoid those forces that HSP causes on your joints, and also ankles as well. And so if that problem does occur, need to know about it, manage it as best we can, painkillers, gentle physio, but you know, if it's prolonged, then you may need to think about, you know, having a piece of titanium put in as well. So that's something to consider. And then the last bit is just a kind of a research thing that we do in our clinic. We take a piece of skin that's about, it's probably about the size of a large pinhead from the top part of your arm. And we want to do more of that, because then I give that to people like Evan Reed in Cambridge. We've given it to the Sheffield guys. We've sent it abroad, all anonymously, you know, but this is where patients have basically allowed research or promoted research by giving fibroblasts to help with that. So that was just a little bit about HSP and management. Now a bit more about the genes. So we can look at HSP and we can split it really into 3 different types, maybe 4. It just depends on how you look at it. But 3 main types are very young children, early onset, under 20, and then the later onset types of HSP. And some patients I put here sporadic or idiopathic. I mean, these are later onset disorders that we think, well, is this HSP or is this not? Sometimes we struggle with the diagnosis as well. And then when we look at the genetics, this is a slide from Viorica, so it's slightly fancy. It comes up with different, the genetics has changed over the last 20 years. So I first started in a lab in 1990, which was in the middle of my medical degree. I did a year out, shall we say, in a genetics lab. And since then, the number of genes has probably risen 50-fold in terms of genes being found. And the little table on the right just shows you the genes and the years that they were found. I mean, I stopped at 2014 just because, you know, you can see the general trend as time goes on, more genes. The commoner ones have been found, but we still find rarer families. And I think probably in 10 years' time, everybody will have a genetic diagnosis. I think that will happen. And the picture here is just to show that the genes have been around for hundreds of years. First described over 100 years ago by this German fellow called Strumpel. They were described, patients were seen, and then the genetics came roughly 100 years later. And if we look at a typical HSP patient, I mean, many of the spastin patients I see classically present in their teens or 20s, scuffing the shoes, maybe people comment about their walking, not good at sport. Then they develop a bit more stiffness, maybe having trouble with cobbles or curbs, bladder problems, back problems, and then sort of eventually diagnosed, but often not for at least 10 years later. And that's a sort of a classical picture of patients. And if we look at spastin, this is fairly what we see with spastin. Age of onset, roughly sort of 20s when we look at all of our patients that we've seen. And this is the commonest gene. We've seen some very young as well. And when we say we look at mutations, we're looking at bits of the gene missing when we look at your DNA. And the bottom figure basically shows the gene with hundreds of little either red squares or different types of mutation. And I don't, it's not something that you need to understand, but it just shows you the different ways that the defects in this gene can cause a very similar clinical problem. And I mean, this is another video. I showed you a video of some patients with spastin, but you may also see patients with very similar types of HSP looking very similar to spastin, but have subtle differences, such as SPG7 patients often have eye problems. This is again, this is from my friends in Australia. And when I examine your eyes, and I will examine all your eyes when I see you, that's usually the thing I do. Many patients, such as this patient here, will have double vision. Many patients will have problems driving, for example, because if your eyes don't move very quickly, that means you have to turn your head to look when you're driving. A lot of patients get neck ache from doing that if they drive a lot. So there are different subtleties to the problems. Video's a bit slow, but when we look at it, this lady's got a typical stiff walk, but she's got also some balance problems, which is another feature we see in some types of HSP more than others. Not just the stiffness, but the balance is particularly affected. And then just a little bit about complex HSP. This slide is probably 5 years old. And then when we did a big screen of our patients, SPG11 was the commonest. But if I did the slide now, SPG7 would be higher than SPG11, and the next one would be SPG15. So over time, we get not only a very broad distribution of genes, but it does change slightly with the different gene screens that we can do. I'll just show you, this is a young man. Again, this is a video from friends. This is a young man with, I think he's SPG 15 or 11. I can't quite see the top of my slide. But he's a patient with one of the spastic paraplasias with a very stiff, slow gait, tremulous and stiff, slow movements of his hands. And when I see patients with complicated HSP, I always think of other medications that will help. And sometimes we give patients Parkinson's drugs, and this can tremendously help the speed of their movements. I mean, he found it quite helpful for his hands because he could then do things such as writing and keyboard. It speeded up his gait a little bit, but the trouble is, as we speeded up his walking, we made him a little bit more poorer balance. That was the only problem with that. But the Parkinson's drug we gave him, Cinemat, really helped with his hand movements. So there are some slight different treatments we use. Okay, so then the last bit is really, I think, the most important, and something I discussed with Adam on the telephone was, how do we get better drugs for you guys? How do we stop the disease from progressing, and how do we treat it better, more effectively? And I think there's three ways, but this is kind of me more brainstorming, and I'm happy for people to chip in at any time after the talk. So we can benefit from other conditions like MS. So baclofen originally was made for MS patients. So, we can take that, we can repurpose drugs for HSP patients. And many of the drugs are given off license because we know that they work in MS, and they do work a little bit in HSP, but it's not very good, shall we say. These tablets weren't made for HSP. The second way is look at gene therapy to switch off genes block or replace genes. This is Huntington's disease. That's probably the most widely publicized disorder that's been treated in this way. Spinal muscular atrophy is another real success in children where they've used a drug to replace the spinal muscular atrophy protein. And that's a real kind of groundbreaking piece of work. The Huntington's disease trial, they've had hit and miss. One of the trials recently failed, but other trials are doing well. But the thing is, at least they've got trials. So I mean, that's something. And then the last part is use, you know, basic research to try and develop treatments based on our knowledge of the disorder. And that's slower because you have to rely on students in the lab. You have to rely on looking at the right pathway and making often slow basic science headway. So they're the three ways, I think. And then what are drug companies looking for in HSP patients to help them? So how can we entice drug companies? Because drug companies want to make money, and that's what they want to do. If we can, you know, if we can entice them to work on disorders like HSP, so that they feel that developing drugs or putting their money initially into developing drugs would help not only HSP but other conditions, this would be a very good thing to do. And here, this is thinking about, you know, developing a UK-wide registry of HSP patients with a genetic diagnosis, so that if a drug was found, then we could immediately email everybody or have a list of telephone numbers and post out details of what their drug is. And then people could say, oh, yes, please, or no, I don't want to be involved in that. Because there will be good and bad in drugs. There will be, you know, there will be risky, there will be mild, there will be, but to have that ability to survey and almost very quickly get the input from a group of patients, I think would be really important. The second bit is drug companies want markers of disease. So they want to know, if they give you a drug, can they do a blood test to show that the HSP is improving, not only from what you say, but also from that blood test. So they want a wet lab test. It's almost like doing your PSA in prostate cancer. So many men, I will say, you know, probably of similar age to me, will have a PSA test looking at their prostate. And if it's high, you've got to be careful about prostate cancer. But the thing is, you do know if it's high, then you have to be careful. But if you treat the prostate, then it goes down, it gets better. And that's what the drug companies want. They want some blood marker that the disease is getting better to show that their drug is working. And that's because they want to sell the drug, of course, but from our angle, that would help us as well, because that would give us evidence that it's working. And the last part is they want blood samples as part of this registry for them to try their future markers of disease on. So not just blood samples. Some companies want urine, for example. I've seen some companies, and unfortunately, when the Huntington's trial was started, they did it on spinal fluid, which is a lot harder to obtain. But that just depends on the drug. And I'll give you an example of this. So there's a rare disorder called multiple system atrophy. Now, it's a rare condition. I see patients with this in clinic, me and Professor Wood. But the disorder is very similar to Parkinson's disease. It's rare, 1 in 10,000, so there's about 10,000 patients in the UK. And there's no treatment, but what research has shown is that there is insulin resistance in both Parkinson's and multiple system atrophy and MSA. So that insulin resistance suggested that was involved in how the disease was caused and how the disease progressed. And then there was going back. This is Gila monster. It's a kind of a lizard. And this lizard only needs to eat twice a year because his venom, his saliva, contains a drug called exenatide. And exenatide increases insulin and reduces other gut hormones. And the question when this enzyme was found is, could we use this to rectify the insulin resistance? And that's what they did in Parkinson's. They synthesized the Gila monster's venom. There was a company that manufactured this. Then I think it was Roche who started a trial in Parkinson's disease of exenatide, and that showed improvement, and that's still ongoing. And then what happened then is Tom Fultoney, who works with me, basically got clearance to use the exenatide in MSA, in a very rare disorder, but got repurposing of exenatide in MSA. And because we collected blood samples, we were able to show that the biomarker, this neurofilament, that goes up in MSA, but it goes down when you treat it. So we were showing that by having a group of MSA patients, by having blood samples, that allowed us to entice a drug company to try this in MSA. So we know it works in Parkinson's, and we hope it works in MSA, and the trial is ongoing at the moment. So it's just an example of how by having this registry, having a group of interested patients, having blood, which you've all kindly given, and many of you have given skin as well, is a way to entice drug companies to do this. Okay, so one of the questions for everybody is, you know, is this something that the HSP Society wants to do? I mean, with the blessing of the society, we have ethics at UCL, we have all the approvals, but one of the things would be to mount energy, shall we say, energy to create a website linked to your website, energy to then to start this off, and to have our registry, to collect our blood samples in all patients. I mean, is this the right thing to do? Is it too imposing on people? Do people not want this? I mean, it's not as if you would give any information apart from your NHS number and your problems. I think this is something that would be good to consider. It's something that would help develop treatments, and it would help develop research as well. And the other thing it may help develop, if you get interested consultants in different parts of the country, it may help them with their diagnosis. It may help them in terms of managing patients as well. So I think that's the last of my slides. So yeah, I always put my acknowledgements, thanking everybody that helps us, everybody that works with us, and today thanking